Hi, everyone. Today I've got a very special guest with me, Dr. Jillian Spencer. You might have seen her on the Spotlight documentary that was aired a couple of weeks ago. Um, we're going to talk about some of the issues that were raised on that documentary. And one of the things that I'd really like to talk about, and I know that Jillian's an expert on this, is why we don't know the long-term regret rate for children that undergo gender medical treatments. So thank you so much for joining us, Jillian, today to talk about these issues. So Jillian, you're a senior child psychiatrist who's spoken out about these issues. And let's start with the basics, I suppose. Did you want to say a few things about yourself and what you do first? And
Sure, yeah. So I'm a child and adolescent psychiatrist. What that means is that I studied medicine down at Monash in your territory.
Yep, that's in my area, yep.
Yeah, and then the pathway is to do a couple of years as a junior doctor in hospitals, and then you start training. And so I started training in psychiatry, which takes 5 years or so, and then became a psychiatrist in 2009, and I did college subspecialty certificates in child and adolescent psychiatry and forensic psychiatry. And then I've worked as a psychiatrist since 2009. And I don't have any political or religious affiliations.
Okay, that's great. And let's start with the real basics. So what is gender dysphoria or gender confusion and distress? So I'm assuming that lots of people watching this wouldn't really know what that means, and maybe if you could explain it for people who don't,
Sure,
mums and dads who don't know about it.
Yeah, well, what might be important for people to know is that in psychiatry, we don't have any blood tests or scans that we can order in order to confirm a diagnosis. What we have are two separate manuals developed by two different organisations. One's called the ICD and one's called the DSM. And within the manuals is listed all the criteria for various mental and behavioural disorders. And so every few years, very senior and influential psychiatrists will get together in meetings and have very heated meetings about the criteria, whether the criteria should stay the same or change, depending on research, but also depending on social and cultural factors. And so the criteria for gender dysphoria, as it's called in the DSM, or gender incongruence of childhood, as it's called in the ICD, is just there in writing for anyone to be able to access and read. It's things like stated desire to be the other sex, fantasies of being the other sex, a preference for opposite sex clothing and playmates and play activities, and also a stated or a dislike of one's own sexual anatomy. With the ICD, they've moved it out of the mental and behavioural disorders section, and they've moved it into conditions related to sexual health because they see that labelling gender dysphoria as a mental illness is stigmatising.
Okay. And so in a clinical practice setting, how would this typically present, and how's that changed sort of over time? Because there was a lot of talk about that on the documentary and in the media about how this has sort of changed over time.
Yeah, well, when I started working in child and adolescent psychiatry, like as a registrar, which is a trainee psychiatrist, in the early 2000s, we didn't see any kids with gender dysphoria. I would have started seeing children presenting with gender dysphoria probably about 2018, although it's a little hard to pinpoint exactly. And what I've seen in terms of the kids presenting is consistent with what we know from the clinics in jurisdictions where they do record the biological sex of the kids presenting. So I don't think that data is available in Australia, but what I've seen is consistent with the data from other clinics, which shows that it's instead of historically prepubescent boys with an earlier cross-sex identification, it's become adolescents, predominantly adolescent females. Often they have a high level of mental health comorbidity and neurodiversity and friends that are transitioning. So the sort of cases that I've seen are kids who have always felt a little bit different. They might have a touch of ASD, they've had a bit of bullying, and then they've formed an idea about why they're different, which is that they're transgender, and then they've immersed themselves in that online and become feeling quite good about being very knowledgeable on the topic. So there's that sort of presentation. I've seen often you get the mostly females who've had sort of a long history of self-harm and self-loathing that are presenting as with a trans identity. You get the kids who have parents who, for various factors, say drug and alcohol problems, or they've been busy working, or for whatever reason they've been somewhat disengaged, and the kids have had a huge amount of internet exposure, and they've sort of found comfort and connection online to replace the family. I guess the saddest thing is that the Department of Child Safety has very affirmative policies, so all the care workers will affirm kids straight away, and so kids in care, have often have quite incredibly difficult histories of trauma. So those kids are often identifying as with or presenting with gender dysphoria.
And for people that might not know, what does affirming care actually mean? Now, I've spoken about this many times when we had this legislation passed through in Victoria, which effectively made it impossible to do anything other than affirmation only. But what does that actually mean?
Yeah, well, affirmation means that you consider that the child presenting with gender dysphoria is actually trans, so that's their true self. And so the first step in the affirmative model is to socially transition, and parents are told to support a social transition and facilitate a social transition as life-saving sort of intervention, even though there's no evidence that it is. The first medical step in the affirmation pathway occurs at the very start of puberty, Tanner stage 2, which is age 10 to 12, and that's when puberty blockers are prescribed. So puberty blockers were originally conceptualized as giving the child time to think, but what we know from their widespread use is that they actually prevent the child from recovering from gender dysphoria, because what is known from the qualitative studies of people that have recovered from gender dysphoria is that it's the course of adolescence that is most likely to aid in that. And that includes, broadening of the social circle and of social activities, some individuation from the family, a sexual awakening and experiences of intimacy. So the full course of puberty is the child's best chance to recover from gender dysphoria.
I've heard it said by people that puberty in some cases can cure this. Like, is that true?
Well, the studies from the studies where they didn't use the affirmation model, so there's no puberty blockers or cross-sex hormones, there's about 11 of them, and they showed that 60 to 90% of kids recovered from gender dysphoria through puberty, became comfortable in their own body. So I think that's what people are getting at when they're talking about adolescence being central for recovery from this condition.
With regards to puberty blockers, can you explain to people like what they actually are? Like what effect do they have in the child?
Yeah, well, just in simple terms, they do stop the body's natural production of testosterone for males or estrogen for females, so that the child doesn't go into puberty. They do have side effects similar to menopause, so hot flushes, fatigue, weight gain, and mood problems. The problem is that they also reduce bone mineralization at a time of life when bones are meant to peak in density, and there's suspected cognitive and emotional effects because puberty is such an important time of brain development.
Yes.
Last year, the FDA put on a warning for a rare but serious condition of which causes raised intracranial pressure, and then there's a particular risk to male children from puberty blockers because they don't develop the tissue they need for the vaginoplasty, and so another part of the body is needed to do that, so they use part of the peritoneum or the colon, which is a much more dangerous surgical procedure.
And some of the other side effects of puberty blockers that I've read about, things like you just spoke about then, physical development, like of the sexual organs, especially in males. So effectively, doesn't your sexual organs don't develop
They
properly,
don't
is
grow.
my understanding. Yeah, they don't
Yeah.
grow. And I've also heard that it can cause problems with sexual functioning as an adult.
Yeah, well, if kids don't go into puberty, then they will be infertile and they won't have the capacity for orgasm.
Right. And
So
this is
that's what happens if kids start puberty blockers at tenor stage 2, age 10 to 12, and they stay on them. And then, as we know, once kids start puberty blockers, 95% of them will go on to cross-sex hormones. So if they have that full affirmation pathway from the start of puberty, then they will have infertility and impairment in their sexual function.
Yeah, and when I first heard this, I actually thought it must be, I don't know, must be wrong or something.
Yeah,
and when I've like it, because it sounds like such a serious impairment to quality of life for people to have that sort of lifelong loss of sexual function. And I think probably lots of people watching this wouldn't be aware of those sort of side effects, that your sexual organs don't develop and that you lose what is considered fairly normal sexual function of things like having an orgasm and these sorts of things.
Yeah, it's really shocking. It's hard to believe that that it would be done, in my opinion.
Yeah, it's quite shocking to me too. So with there's been a lot of concern internationally about both the affirmation only model and also the use of puberty blockers and cross-sex hormones in children and adolescents. What probably the biggest case of this was in the United Kingdom with the Tavistock Gender Clinic, and I'm sure you're well across that. Could you maybe give some brief summary of like what went on there and what was the aftermath of what happened in the UK?
Sure. Yeah, well, the Tavistock faced a series of problems. So they had a massive increase in the number of referrals, and the referrals that they got, it was a changed demographic. So as I've mentioned, the adolescent demographic rather than prepubescent boys. And then, so they had very high workload on waiting lists with a lot of pressure on clinicians, and the clinicians felt under pressure to push kids through quickly and affirm the kids. Some clinicians were really into affirming, and then others were feeling very concerned that they were affirming kids who had complex trauma or had parents who were just openly expressing homophobia. And so in that setting of being ideologically captured and then high pressure and workload, they had a lot of clinicians leaving, and then they had recruitment problems. They brought in a lot of junior staff. And then when they did research or became aware of complications with the puberty blockers, like the high continuation rate, so affecting the natural rate of healing from gender dysphoria, and also the issue with the more dangerous surgery for vaginoplasty because the tissue not developing, the staff wanted to update the consent forms and the patient information handouts, but the management didn't want to do that. They also had issues with management being overly connected to advocacy groups for transgender people, which in the UK case was mermaids. And they had a really defensive management style so that they didn't listen to internal staff concerns or external staff concerns. And so that all led to a massive amount of concern. And they had some key case, Kira Bell, going through the courts to try and point out the problems with the clinic and with the model, with the affirmation model. And eventually the government called an inquiry, which is the CAS review. And then that started in September 2020.
Yeah, and the CAS review is identified many of these problems, and I've been openly calling for a review similar to the CAS review in Australia, and I know I'm not the only one doing that. But
yeah, because I'll just jump in there because as part of the CAS review, the National Institute of Health and Care Excellence in the UK conducted 2 systematic reviews, one of puberty blockers and one of cross-sex hormones. And they found that there isn't evidence of benefit from the puberty blockers or cross-sex hormones. And that has been the finding time and time again when states or countries conduct systematic reviews, that they're finding that there isn't sufficient evidence to justify these interventions, given that they've got such significant harms. And all indicators are that when the final CAS report is due out later this year, that they're once again going to conclude that there isn't sufficient evidence, and they will, as of May, CAS's last letter to the NHS was saying that they were likely to be putting puberty blockers within clinical trials only.
And it's the UK is not the only country that's been going through this sort of evolution in looking at the data and looking at the science. I know Sweden and some other Scandinavian countries have been looking at this. Also, some jurisdictions in the United States and even Canada, I think.
I don't know about Canada, but
yeah, okay,
yeah.
I think
Sweden,
Canada was maybe talking
Finland.
about social transitioning, but
right, yeah.
Yeah. So it's clear that lots of countries have been looking at this. And in your opinion, though, do you think that some of the problems that the CAS review identified that were happening in the UK, are those problems happening here also?
Oh, definitely. The problems with the Tavistock are happening here. I think it's worse here.
Right.
Not just because, they had just the Tavistock Gender Identity Development Service and we've got multiple clinics, but as far as I know, they never had conversion therapy legislation in the UK. And they didn't have a professional registration board getting complaints if people didn't affirm patients with, mental health clinicians and doctors being scared across Australia of losing their registration if they don't take an affirming approach. So what's happened in Australia is that compared to the UK, where they just had the Tavistock clinic and everyone outside of the clinic was like, oh, that's a bit weird. In Australia, the affirmation model has leaked to all the other child and youth mental health services. So they're all obliged to take this affirming approach, which is what happened to me, in that I wasn't working in a gender clinic. I was working just in a general child and adolescent mental health service. And I was, formally directed to always take an affirming approach towards children, always use their preferred pronouns from the moment I meet them, and always refer any gender questioning children to the gender clinic. So I think we've got it worse here.
Yeah. And this was one of my big concerns when this legislation went through in Victoria in 2021, and why I opposed it. One of the reasons that I opposed it is because I had concerns about this affirmation model. And I think you mentioned before one of the key issues around this, and I think this was covered in Spotlight, in that not everyone who thinks they're transgender, not every child who thinks that actually goes through to believe that when they're an adult, right? And we spoke to what they call detransitioners. I've spoken to many. I'm sure you've spoken to many as well, and some were interviewed on Spotlight the other night. So the existence of detransitioners proves that this affirmation model is not always correct. Now, when this is brought up, and it was even brought up on Spotlight with Professor Hickey, and when he was presented with that idea, and many other people who, like activists and stuff that I've spoken to, they sort of dismiss this and say, oh, it's a tiny percentage that regret going through these treatments. It's they say 1% regret rate or something like this. Now, my understanding is that science, or that 1% regret rate, is not a very strong body of evidence, and that actually over the long term, because my understanding is that it actually takes many years for someone to decide to detransition. It's not something that they do immediately normally. Can you maybe talk a bit about, what we actually know about maybe this 1% rate, and also what we know about children who've undergone these treatments over the long term? What do we think? What do we know? What does the science tell us about those regret rates?
Sure. Yeah. Well, that less than 1% regret rate that you see a lot, that's based on two different studies, which don't have any applicability whatsoever to adolescents and hormones. Both of those studies are applicable to adults after gender surgery, so adults that have had gender surgery. They're both very unreliable studies. The first one is one out of the Dutch clinic that was published in 2018. And what they did there is look at all their patients from 1972 through to 2015, 1972 through to 2015, and they did a chart review, and they had a really high bar for assessing regret. So in order to be considered a regretter, you had to have had a gonadectomy, which means you've had to gone to the extent of having your ovaries or testicles removed, and then you've had to come back to the clinic and expressed regret, and for that to have been documented in the chart, and then they've got to have returned to taking their biological sex hormones. So that's an incredibly high bar to consider someone a regretter. And say, for example, Mel Jeffries on Spotlight, she wouldn't fall under that definition because of not having had a gonadectomy, and Kira Bell in the UK similarly.
In fact, most detransitioners I've spoken to wouldn't meet that.
No.
So, just to clarify for people watching, if someone had, if there was a female who had undergone puberty blockers, had taken testosterone, cross-sex hormones, had undergone a double mastectomy, and then later regretted it and decided to lose contact with the clinic and not take any more drugs, they wouldn't qualify under this definition. Is that correct?
Yeah, that's correct. And you've brought up the other point, is that these people had to get back to the clinic and express regret. And what we know from detransitioners is that they're so full of pain and a sense of being hurt and betrayal that they often, they don't want to go back to the clinic.
Well, they don't trust them, of course.
Yeah.
I mean, many that I've spoken to are angry at the doctors that treated them, and the idea of going back to them for further treatment is just unthinkable to them.
And so the second study that they used to make this false claim of a less than 1% regret rate is it's a mess of a study. It's 27. It's a pooling of 27 small studies of adults, or vast majority adults, having gender surgery. And so it's all these little studies with very poor methodological studies. So these studies are small. They have massive dropouts, lost to follow-up, or they have invalid assessment measures for regret. And they've put them all together, and then they've done data extraction errors even from the studies that they've pooled, so that the numbers aren't right. And then they've put it all together in an absolute mess and said, only 1% of people regret, gender affirming surgery. So it has no applicability to adolescence and hormones. It's tricky because like gender clinics, say, for example, in Australia, don't collect long-term data, although I guess the Royal Children's is meant to be doing that with their Trans 20 study from 2017, but they haven't published anything on that yet. Probably the most reliable evidence we've got is from an American study, Roberts et al. In, I think, 2022, which was a study of the family members of military veterans who...
Yes, I've read about that.
Yeah, and they were quite careful in that they made sure that people were having ongoing healthcare, so that they weren't assessing people who stopped taking their hormones and mixing them up with people who just dropped out of healthcare. So they found people who had been diagnosed with a gender dysphoria or associated diagnosis and had been prescribed cross-sex hormones and had taken the hormones for a period of 6 months. And then they looked to see how many of them stopped taking their hormones for a period of at least 90 days. And the average age at the start of the study was 19. And what they found was 1/5, so 20% of males, and 1/4, 33%-ish of females stopped taking their cross-sex hormones by the 4-year mark. But the truth is that we really don't know the regret rate or the desistance rate, because we haven't got the long-term studies. They've never been done, and they certainly haven't been done in this modern cohort of adolescents presenting with gender dysphoria.
Yeah, and this is the conclusion I've come to as well, is that we just don't know, right? We just don't know long term what sort of effect this is going to have, both on terms of how many children are going to regret this when they're adults, when they get into their 20s and 30s. But also it seems like we don't really know the long term effects of things like puberty blockers and cross-sex hormones over the long term. We've spoken about some of the shorter term effects of cross-sex hormones, like things like bone mineralization, potential
that's the puberty blockers. The cross-sex hormones, the effects depend on whether you're male or female. And so, say, for example, for females taking testosterone, they've got higher cardiovascular morbidity and mortality, And for males taking estrogen, they've got high rates of some cancers and strokes from venous clots.
Yeah, and all of this that we're talking about is not even talking about like totally ignoring gender reassignment surgery, which typically happens when you're an adult, but that's like a whole another thing. All we're talking about here really is taking these puberty blockers and cross-sex hormones, and yeah, like
True. Although I will say that 15-year-olds are having mastectomies in Australia, and there was a family court case, re Lincoln 2016, where the family court authorised that, and they authorised that because they were told by the gender clinic doctors that a double mastectomy in a 15-year-old was necessary and necessary healthcare. So it is happening, and there was a subsequent decision, re Matthew, in 2018, which meant that court authorisation was no longer required. So that's put it behind closed doors and made it easier for people to say it's not happening when it is.
And yeah, I saw a letter recently challenging that as well, that whole court case. But with regards to what's going on here and what's going on with the treatments, it sounds like you've come to some point where you've said, I need to speak out, right? Tavistock in the UK, there was some people that bravely spoke out and risked their careers and all of that sort of stuff. And you've decided to speak out in Australia. Like what motivated you to do that? Because it's great personal risk, right?
Yes, yeah, it is, unfortunately. But well, it's mainly I feel very worried about the risk of regret, and those when the stories of the detransitioners are heartbreaking. I also feel really concerned that parents are getting bamboozled by having a child with gender dysphoria, and then they're going to health services, and they're sort of getting railroaded into affirming their child on the grounds that it's going to reduce their child's risk of dying by suicide, and that's not true. So I feel very concerned about families and about the regrets. I really worry because I know that the gender clinics, they keep telling people that they're doing very careful multidisciplinary assessments, but that's a bit deceptive, because what they're not telling you is that even if you did 100 assessment sessions and you included every health discipline in those assessments, you still can't tell whether a child with gender dysphoria is going to have gender dysphoria into adulthood. And the concept of a multidisciplinary team is meaningless when you have all the clinicians in the team contractually obliged to follow the affirmation model. And so what the gender clinics actually are, they're not mental health services, they're rapid assessment and treatment services, and the only treatment they offer is the affirmation model.
Yeah, it's quite weird in most medicine. You have someone that's ill, like something's wrong with their body, and then they go to the doctor, and then the doctor's trying to fix them. In this case, it's quite different. There's nothing wrong with their body until they get treatment from the doctor, which causes issues, and yet they say it's life-saving care. Like, what's the justification for that? Like you said, like it's like usually what they say is like people are going to self-harm, right? And that's why it's life-saving. What's your view on that sort of justification for providing these treatments?
Yeah, well, there's no evidence that these interventions do reduce the suicide risk, and not social transition, not puberty blockers, and not cross-sex hormones. What's really important for people to know is that luckily for child psychiatrists and everyone working in child mental health, the suicide rate for children is low, thank goodness. But it is the case that in child and adolescent psychiatry, you see kids all the time who are talking about suicide with all sincerity. And so it wouldn't be uncommon for a child with anorexia to say that they'll attempt to kill themselves if they're made to put on weight, or a child with school refusal to say that they will attempt to kill themselves if they're made to go to school. But in every case, we always just provide maximal supervision and support, and we continue on with the treatment that they need in order to recover from their condition. I think this affirming model is really tricky because it sort of upends the family structure and puts parents in a really weak and frightened position, not just because they're scared of suicide risk, but they're also scared of their child cutting them off, because they know that online people are telling their child that if their parents don't affirm them, then their parents are, hate-filled bigots and they need to be cut off. So unfortunately, it really upends the power dynamics in the family. And in some cases, I think that deprives the child of the very strong and confident parenting that they need.
Dr. Spencer, thank you so much for speaking with us about these issues today. I know that there's lots of parents out there who are really concerned and interested in this and would really appreciate hearing your perspective and views on this. So thank you so much for speaking with me today.
My pleasure. Thanks for talking to me.
No worries. Thank you.